Hi, my name's Michelle Morand, and I'm here today with Alexander Rolland, the cancer guy. And we're here to give you an update, or Alex is going to share an update specific to a HER2 breast cancer patient and some of the amazing success that they're experiencing now. But this conversation is also relevant for anybody with HER2 positive cancer. And if you haven't been tested for HER2, even if you have, prostate, lung, liver, or whatever type of cancer, stay tuned because Alex is going to talk about how this particular issue is relevant to many different types of cancers and some exciting new treatments for that. But specifically, we're going to give you a bit of an update. Alex, go ahead.
I actually just spoke with the patient today. I think this really outlines some really important key questions here, such as what to do if you have a HER2 positive breast cancer, what to consider, but most importantly, understanding what HER2 is and what HER2 targeting is and why it's such a big thing in cancer these days.
So recap, you're going to share the story, but the reason for sharing is because this is so relevant to so many people, not just breast cancer patients, but other types of cancer. And there's a lot of misunderstanding in the medical system about this, which you're going to share with us. So stay tuned. Go ahead, Alex.
First slide, how to identify best treatments for HER2 positive breast cancer, but this applies to all HER2 cancers. Herceptin, HER2 positive breast cancers are typically treated with Herceptin. Herceptin's kind of the poster child of precision oncology. It's one of the first targeted therapies. It's a monoclonal antibody that binds to the HER2 receptor. The HER2 receptor is basically it's a receptor, which is kind of like a loading dock of a furniture store, receptor on the outside of HER2 positive breast cancers. And in this particular case, if you have HER2 positive breast cancer, you're typically given Herceptin and chemotherapy. Now, Herceptin binds to what we call the juxtamembrane domain. I believe that is domain 2. Don't quote me on that. However, there's also been another drug since then called pertuzumab. That's it. This drug works by binding the fourth domain of the HER2 receptor. And so when you have a combination of two different drugs that actually bind different parts of the receptor, then you're going to probably get a better response because some tumor cells may have a mutated HER2 receptor where the second domain is missing or the fourth domain is missing, and in those cases the drug wouldn't bind the receptor. But so when you use this, you get a more effective targeting of the tumor cells. There's actually a new drug now that targets both domains. Just came out. Yeah, so the scientific data does show that you get a much better response when you're combining both of these drugs. And that's because they bind different parts of the HER2 receptor. However, there's a lot of back and forth on this, and not all of the clinical trials were very clear. So it gets a lot more complicated than just this. And I'm going to explain why there's some confusion on this.
Part of the reason why we're sharing this with you is first and foremost, so you're very well educated, but also because you might hear some other information from your doctor about why this isn't relevant or why they can't get access to something. And we want you to be really aware of the facts here.
Typically, the benefits of this combination are more profound in more aggressive cases and those with lymph node metastasis. And additionally, we know now, from looking at HER2 targeting in different types of cancers, we know that having HER2 gene amplification in addition to HER2 overexpression results in much better efficacy of these drugs. And in fact, you're less likely to become resistant to HER2 targeted therapies if you have HER2 gene amplification in your tumor. We'll get into discussing what that means. Unfortunately, sadly, in Canada, now, this used to be the case. Pertuzumab was covered for a while. Lots of patients were getting it. But now it's not really covered for all HER2 patients. It's really important for certain patients. This is probably based on a lack of understanding. I hear from doctors that they say, oh, it doesn't really make a difference. There was a trial to say it didn't really make a difference, but there was a good explanation for that. So it's really about understanding how this works and why and what the variation is and when it's going to work and when it should be used, okay? So what is overexpression and what is gene amplification? Overexpression, as you can see on the left, this is a normal breast cell, and the normal breast cell has the HER2 receptor on the outside of it. As you can see, there's a nucleus with the HER2 gene. It's also known as ERB2, but we'll just call it HER2. And so basically what happens in overexpression is the switch for the gene, which is called the promoter, gets turned on, and the gene produces a bunch of these HER2 receptors. And then in a normal situation, that gene would get turned off. What happens in HER2 positive breast cancers is that gene gets stuck turned on, and you end up with a bunch of receptors, just like the image on the far right here. And so that's based on HER2 overexpression. Now, what can also happen, although this is not always the case, is cancers often copy DNA. They copy chromosomes, they copy genes, and so on. It's not so much that the cancers actually copy this. What happens is a copying process results in cancer. And the copying process is usually based on reactivation of these things called, they're basically called endogenous retroviral sequences. And what they are is they're viral sequences that have been incorporated into our genome over millions and millions of years from a class of viruses called retroviruses. And these retroviruses, what they do is they have us copy their DNA or RNA or whatever it may be. And so the remnants of these genes are still in our genome, in the junk DNA. And every now and then, one of these genes gets turned on, and it just starts randomly copying genes. So in this particular case, what it's done is it's actually produced multiple copies of the HER2 gene. So not only is the gene turned on too much, which is expression or overexpression, but there's also multiple copies of the HER2 gene. Now, one thing that is really important to understand is just because you see multiple copies, it doesn't mean that they're functional copies. They may be damaged copies, and they're not functional, and they're not going to be able to contribute to increased HER2 expression. So HER2 gene copy numbers, increases in them, amplification, can result in increased expression, but it's not the only mechanism that causes overexpression. You can also have the gene turned on for too long. And so they're two completely individual things. This is the important thing to understand here.
So let me just clarify. Overexpression is the gene is turned on too much.
Yes.
And amplification is we have many copies of the same gene.
Right.
Okay.
Exactly. Yeah. The takeaway here is that typically tumor DNA sequencing, unfortunately, is not done in breast cancers as routinely. I mean, we do it for every breast cancer, and we wouldn't be able to, help our patients guide decisions if they didn't get tumor DNA sequencing. It's fundamentally important to determine which one of these amazing new drugs we have is going to benefit you or not. And
right.
many, many cases where a patient is not responding to treatment, the standard treatment that they should be, it's because they have unique molecular features that could potentially be targeted with different drugs.
Yeah, and just to be clear, if you're just getting started looking into precision cancer medicine, we're talking about one specific thing right now. There are many hundreds of genes that can be tested for, and many hundreds of different targeted therapies. So if you don't think HER2 is relevant to you, just understand this information about the value of figuring out what's driving your bus as a breast cancer patient or other type of cancer patient is really critical.
Mm-hmm. And so here's where the confusion lies. Okay. Is, number one, that typically tumor DNA sequencing is not done for breast cancer, so we don't have a lot of data on it. Knowing the different types of gene alterations versus, mutations, small deletions, fusion proteins, there's so many different types of alterations that can happen to a gene that result in it having altered activity that results in cancer. So that's not part of medical training. That's part of molecular biology and geneticists. So it's a very confusing field, and there's a lot going on there. Importantly, too, this has really confused the studies, is the amplification of HER2 does not always result in increased expression, as I said in the previous slide. And you may say, well, who cares? Well, it's confused studies. So when they look at amplification and they say, well, it doesn't make a difference in this case, and then this other case, it does make a difference. We can't really have any conclusions on this. Mm-hmm. And that's because you need to understand whether the amplification is actually part of the mechanism.
Point is, you can have amplification without overexpression. Mm-hmm. And some of these studies that doctors might be using to decide that this drug isn't beneficial didn't understand this or confuse these concepts. And so they didn't appreciate the benefit of this drug.
Yeah, and that's one of them. That's one of the things I see a lot of when medical doctors start using tumor DNA sequencing. They often mistake that. They see amplification, and they think, oh, well, I'll just put the patient on a drug that targets that, and it doesn't always work.
Right. So testing for both amplification, is this mutation present?
As well as expression.
The expression is how we know not only do you have this mutation, but it is specifically involved and significantly involved in your cancer.
Yeah, exactly. Yeah. Exactly. Okay.
But right now, typically in standard of care, neither of those things is being tested for, really, sadly.
Yes.
Yeah.
Yeah. So I want to talk about a case example. I just spoke with a young lady today, a lovely young lady who's very proactive in her cancer treatment. Just recently diagnosed. She had an aggressive cancer. It was grade 3. It had some positive lymph nodes, and it was HER2 positive. And she wanted to make sure she was doing everything she could. So she had, I believe, a free consult with us. And in that free consult, I urged her to get pertuzumab along with Herceptin, mostly because the studies where you have high grade or it's aggressive cancer, and it's aggressive cancer if it happens in a patient who's under the age of 50. If you have metastasis in your lymph node, then the data is really clear. Herceptin and pertuzumab really do make a difference. The gray area is if you have a less aggressive disease, grade 2, and you don't have any metastasis in the lymph nodes. So what we did is we urged her to get pertuzumab, and her doctor who was involved in studies of it said, I'm sorry, we can't get it covered, but I'm happy to write your prescription for it. I was involved in the studies. I do believe it's a good thing, but unfortunately we can't get it covered, but I can get your discount on it, some compassionate access. And so he was able to get her a self-pay program, with the costs greatly reduced. We also did tumor DNA sequencing on her to establish exactly what's going on and whether she had HER2 amplification and what other genetic alterations could provide treatment options for her. So in this particular case, we found that she had on average 8.8 copies of the HER2 gene in her tumors. So HER2 3+ by IHC or FISH or any of these tests, they usually have 5, maybe 6 copies of the HER2 gene. So having almost 9 copies means that, that's definitely amplified. Now, the patient also, interestingly, had damage to both, not only the BRCA1 and 2, but the BRCA2 gene as well. So we know that PARP inhibitors, another class of targeted therapy, will be very effective for her at some point in time. However, we knew right away that she would have an exceptional response from dual HER2 therapy. Number one, because dual HER2 therapy works really well. It's got about a disease-free survival, probably in the high 90s, 95% or so in these cases when you use a dual combination. But also she had this copy number variation. And the data is pretty clear that if you have copy number variation and high expression, then you are going to have an exceptional response to dual HER2. I spoke with her today, and she said her doctor is really happy with the response. She's only had 2 treatments. So 2 treatments already. She said all the tumors are gone. She can't feel them anymore. The doctor couldn't feel them. And she said just basically all the lumps are gone. And that's only after 2 treatments. So, I think she was pretty excited about that.
So I'm assuming we're not just feeling for lumps. She will have a scan of some sort.
Of course, yes. Yeah. Now, here's the $1 million question. There was a recent study that just came out this year that discussed the fact of whether someone with dual HER2 therapy on her, HER2 positive breast cancer, whether they could skip chemo. And so typically it's 6 cycles of chemo and HER2 treatment before, and then you get surgery. That's a neoadjuvant setting. So in this particular case, this patient probably could have skipped the chemo. And the reason is a recent study called the Fergain, I believe it is. In this, I think 50% of the patients had node positive HER2 breast cancer, and it ranged in stage from 1 to 3. Now, we're going to cover this study in another presentation. We don't have enough time to cover it today, but I just want to say why we're saying this person might have been able to skip chemo. So in this particular study, they had 2 groups. They had patients who were only getting the dual HER2, Herceptin and pertuzumab, and then patients that were getting the dual HER2 plus chemo. And so what they did with the patients who were getting just the HER2 is after 2 doses, if the patients had their tumors shrink and disappear, and this is based on a PET scan, they gave them a PET CT scan after the first 2 treatments, then they were able to continue treatment without chemo. If their tumors hadn't responded to the dual HER2, then they would be given chemo. So I think this is the approach that should be used as a standard new approach, because it will probably allow a lot of patients to skip chemo and, avoid some of the toxic side effects like neuropathy and so on of chemo. But in this particular case, because the patient had such an exceptional response after 2 treatments, they probably were one of these people. And I suspect if we look into it in more detail, we'll find that if you have HER2 amplification and high HER2 expression, then there probably is an option for you to skip chemo. Now, we call this chemo de-escalation. So we don't just say, hey, let's just skip chemo and let's forget about it. It's important, if you are going to skip chemo, get a PET CT after the first 2 treatments to ensure that all the tumors are gone. So a summary for HER2 positive breast cancer patients, what to do for the best outcome. And this applies to, most cancers of HER2 positivity. Number 1, always get tumor DNA sequencing. Not just for the HER2 gene, but you want to know if there's any other molecular alterations that can prevent these HER2 targeted therapies from working. You also want to know if you have HER2 mutations, because if you have a HER2 mutation, these 2 drugs are not going to work for you, especially if that mutation is in the external portion, like the domain 2 or the domain 4, or any external portion of the HER2 receptor. Because what it's going to do is it's going to change the structure of the HER2 receptor, and both Herceptin and pertuzumab won't be able to bind. So if you have a HER2 mutation that you detect through tumor DNA sequencing, then you go on a different drug called neratinib, and that actually goes inside of the cell and interferes with the internal components of the HER2 gene, not just the external components. So DNA sequencing, super important. If you have an aggressive cancer with grade 3 or lymph node metastasis, or you are a young patient under 50, then definitely get Herceptin plus pertuzumab. It's a no-brainer. And if you have HER2 gene amplification, you should get an exceptional response.
That's wonderful. I want to come back to what you're saying about tumor DNA sequencing, because so often patients are told, we tested your tumor and you don't have any markers. And I really need to make sure that you watching at home understand what your doctor is actually saying to you when they're saying that. They're saying either they just did an inherited mutations test to see if your BRCA1 and 2 may be an inherited mutation, or they used a very small panel, which is very common in standard of care, to look at the most common from like 12 years ago genes associated with your type of cancer. It's not possible for you to have cancer and not have mutations that have caused it and are driving it, and very often have excellent targeted therapies to go with them. So first of all, if you hear your doctor say, we tested you, you don't have any markers, or don't waste your time on sequencing, it won't tell you anything, please understand that your doctor is one of the 80% of physicians who does not understand how and when to use genetic testing to inform patient care.
We know a lot of geneticists and molecular biologists and cell biologists that do not understand all of the variations of mutations that cause cancer. It's just not part of what they probably learned it at some point in time, way back when in biochemistry 300 or something, but have just not needed to use it.
Yeah, and that's right. So for whatever reason, but a study from just this last year, it's so important to just understand as a patient. Only 20% of physicians surveyed said they felt that they had even moderate understanding of how and when to use genetic testing to inform their patient care. It is such an important statistic for you to remember, because your doctor will absolutely want to do their best for you, and they will believe they're doing their best for you. But if you hear your doctor say you don't have any markers, or you don't need any sequencing, we already know what treatment to give you, that's when a red flag needs to go off for you. And you need to understand that however well-intended your doctor is, they're lacking a lot of information, and they're not able to provide you with the most accurate and thorough diagnosis. And that means your treatment isn't going to be as beneficial as it could be. Right. I need you to understand that. It's really, really important. Every day I get calls from people who are, late stage 4, who just they just trusted that because their doctor said they didn't have any markers, that there was no point in getting any genetics done, or that they had already had genetic testing done, and that's not okay. Having said that, we can still help people who are late stage 4 or stage 4 with metastasis to bone and various other things. These drugs are amazing, but you must get the testing to find out what drug is going to suit you best. I also wanted to say that in public health, healthcare, a lot of times, if your doctor is somewhat on the ball around this and they are trying to get you testing, they will again use a fairly small panel simply because they're trying perhaps to be mindful of your budget, or that's what they have access to. It's important that you understand that for tumor DNA sequencing, right now we understand that there are at least 550 plus known genes that can be tested for that are commonly associated in cancers. So it's very important that you ask your doctor, how many genes did you test for? And which ones did you test for?
And more importantly, how many mutations within that gene were looked at? Because often these tests will look at like 2 or 3 mutations per gene. And I mean, the amount of mutations you can have just in a small piece of DNA of a gene is more than all of the atoms in the known universe. So, an infinite number that is not even calculable on a standard calculator of possible mutations in one gene.
But which can be tested for.
Yes.
Is key. So yeah, so asking, if you're told you don't have any markers, ask for details. Don't just accept that because it's not physically possible. And then ask for information about, well, what did you specifically, please, may I have the list of genes you tested me for? And was it the whole gene or just a particular mutation? That's so important. What I don't want is for you to assume you've asked the right question, could I have testing, and either got shot down or were told you had it, and there are no options for this kind of information that Alex is offering. These kinds of tests, like a HER2 test, is actually quite economical and financially accessible, and what it provides you in terms of the outcome of your treatment is phenomenal. So let us know if we can be of assistance. If you'd like to speak with Alex, the consultation link here will take you to a page where you can sign up for a 1-hour consult with Alex. Before you meet with him, we'll gather your medical records. He and his team of researchers and MDs will go through your file, and they'll look at the most current research, and they'll meet with you and share with you everything that can be done with the data that exists right now. And almost every time you're able to come up with a couple of treatment options and then some recommendations for further diagnostics. So it's definitely well worth your time. Okay, thanks, Alex. Thanks for sharing this.